And now it's our pleasure to introduce Federico Bilotta from Roma with this very beautiful picture on your talk. So welcome, Federico, and we are going to listen to you.
Merci beaucoup. J'ai apprécié beaucoup que votre invité à contribuer à cet congrès. Je parle un peu de français, mais ce n'est pas suffisant pour faire une lecture scientifique. Puis, if for you is okay, I will shift to English. That is more familiar.
Anyway, we are supposed to talk in English, so it's perfect.
Thank you. So, come mostro il mio schermo? Here, can you see my slides?
Yes, absolutely.
Okay, so my topic will be on cerebral protection, but as I'm trying to do generally, I bring some art to make it the topic, let's say, more interesting, or interesting in a more wider perspective. For this presentation, I choose one painting from Piero della Francesca, that is the flagellation. And what is interesting is that Piero della Francesca is known for his beautiful sky. You know, the light he represents is a unique landmark of his painting. But in this painting, he also reports two scenes that seems to happen simultaneously. One on the left is the flagellation of Jesus, and on the right there are three people talking each other. But these two scenes do not take place actually simultaneously. As you can see, the people on the right are dressed in a very different way. The more interesting and the point that connect to this lecture is the scene on the left. As you can see, there is one person standing and watching the flagellation, the lambasting of Jesus, without doing anything. And this is the point where I intended to start from. This is exactly what we shouldn't do when our patient goes under surgery. You know, we should do something, not just witness the potential damage without taking an action. So what we can do. We will talk more about this figure, is the Giovanni Paleologo, the last emperor of Constantinople. Now, how we will develop the topic on brain protection. First, we should know which are the various forms of brain damage that can happen throughout the procedure and after the procedure, which are the mechanisms and which are the don't do and the do to protect the brain. As you can see, Giovanni Paleologo has been represented in various other paintings. This is another representation because, of course, being an emperor, he was a very famous person, but he was also the one that, let's say, lost Constantinople to the West. So this is the reason why he's represented by Piero della Francesca as just, you know, standing without reacting. The impact of anesthesia on the brain function was reported first in 1955, and Bedford published in Lancet this note, this case report that concludes saying he never been the same since his operation. So since then, the impact of anesthesia, the protracted, the post-operative impact of anesthesia on the brain has been more structured. And we now know that we have at least three major figures. So the new onset post-operative neurological deficit that might range between motor deficit and visual loss or spinal cord ischemia that are relatively rare. The postoperative cognitive dysfunction, we will see in a minute that there is a new nomenclature on this item, and the postoperative delirium. So we have at least three figures that have different impact on the clinical course. Regarding postoperative cognitive dysfunction, this was described in detail by a huge study published in 1998, again in The Lancet, and it was reported to complicate up to 25% 1 week after surgery, but more interestingly, to last in up to 10% of the patients after 3 months of surgery. This is a relatively recent review article we have published on postoperative delirium and postoperative cognitive dysfunction. What is interesting is that there are some to do that connected these two conditions. For instance, it's very important to evaluate, to include in the preoperative evaluation a functional and cognitive evaluation of the patient, but also some risk factors as albumin concentration and dehydration are relevant for both of these conditions, as it is important to monitor, to include in the post-anesthesia workup an evaluation, a systematic evaluation of the cognitive status of the patient. So this is new, let's say, relatively new and important. I mean, should be implemented in our routine clinical practice. The other point is that relatively recently, we understood that repeated anesthesia expose our patient to have an higher impact on their cognitive function. So we know that anesthesia is safe. We made it safe. At large, we now have, better drugs, higher ability managing the airways, and when necessary, to use as alternative local regional techniques. But we should be aware, and this should be included in the balance between surgical indication that repeated anesthesia, that is not only anesthesia, is the entire process of being hospitalized, undergoing surgery, and receive anesthesia, expose the patient to a risk of permanent or more serious impairment in his or her cognitive function. So I was referring to this paper. This was published a couple of years ago in Anesthesia. Actually, it was published in several journals at once. And the interesting point is that the authors highlight how postoperative cognitive dysfunction should be rather named, should be rather considered as delayed neurocognitive recovery. And delayed neurocognitive recovery might suggest how this process is eventually can benefit of interventional strategies, like what we can consider dedicated cognitive exercising. So here again is our Giovanni Paleologo. As you can see here, the figure represented by Benozzo Gozzoli in Firenze and Palazzo Medici is much like a traditional emperor, visiting a city, while the lecture given by Piero della Francesca is much more controversial and challenging. So which are the mechanisms, which are the factors that can favor occurrence of one of the forms we have seen of postoperative cognitive dysfunction, new neurological deficit, or postoperative delirium. What is interesting is that postoperative hypotension is not a major mechanism for associated with new neurological deficit, but anemia might be. So we know that sometimes or relatively or often hemoglobin loss complicates the preoperative course, so we should be aware that severe anemia and eventually in more fragile patients, some levels of anemia might represent an additional risk factors. What is very interesting, and this connected to the previous lecture, excessive ventilation, I mean inducing hypocapnia, is a risk factor for postoperative brain damage. So here is a point where we link inappropriate ventilation with brain damage. And this was also confirmed in a more recent study where 20 patients have been exposed preoperatively to some hypocapnic trial, hyperventilation trial, and this study showed how some patients are especially sensitive to hyperventilation-induced hypocapnia in presenting postoperative delirium. Again, also this point connects with the previous lecture. An excess of oxygen, inspired oxygen fraction, might cause, possibly through cerebral vasoconstriction, might cause an increased release of biomarkers of cerebral damage. So too much of ventilation, too much of oxygen is bad, not only for the lungs, but also for the brain. And another mechanism that have been involved in the brain damage associated with anesthesia, and I would say, and underlying again, perioperative period at large, is inflammation. We can clearly see how different techniques, different pharmacological approach have different impact on systemic inflammation. And also in this case, as reported for ventilation, there is a difference between intravenous and inhalational drugs. Cerebral emboli, we know that from cardiac surgery, are a potential source of cerebral damage. This, of course, applies especially to persistent new onset neurological damage. And in this case, it's important to note and to screen for patent foramen ovale and carotid stenosis. So these are the mechanisms. Also extremely interesting is this study that compared general anesthesia or spinal anesthesia in patients undergoing shockwave lithotripsy. What is interesting is that general anesthesia seems to be associated with the same risk of developing postoperative cognitive dysfunction. And when we do a protocol analysis, we comes to the evidence that general anesthesia associates with even less severe, less frequent impact on cognitive dysfunction. So, as I'm saying, it's not general anesthesia per se, but possibly is the entire process of undergoing surgery, hospitalization, and certainly anesthesia plays a role. So what we can do, I mean, we have seen that there is the risk, there are some mechanisms, is there something we can do? First, there is an intense and extensive production of studies that report on various monitoring techniques. I mean, I know that with saying this, I might touch some interest, but the truth is that according to this Cochrane database systematic review, evidence on the benefits associated with direct brain monitoring are still lacking. I'm not saying that they will not come, but I'm just underlying how an excess of information might associate with the potential of being misleading. We know that pulse oximetry is important. We know arterial pressure is important. We know that there are some monitoring devices, some monitoring approaches that are relevant. We know that anemia is important. We don't know if monitoring the brain is important. So this, of course, might be suitable for future studies, but current evidence are lacking on the indicating a clear benefit, both for NIRS and BIS. This is the impact of
just we have 1 last minute. So.
Yeah, I know, I'm checking it. Pharmacological preoperative brain neuroprotection. This is a long story. Make it short. Drugs cannot protect the brain. The issue that thiopental, barbiturates, or propofol can exert a neuroprotection is not true, period. Similarly, systematic administration of steroids that is not effective, and is interesting to note that the use of some colloids associates with an increased risk of delirium. So certainly for hydroxyethyl starch, there is a mark of attention, and at large, colloids should be used with extremely, prudency. What we can do, supporting the perfusion is important. As you can see in this study, in elderly patients, when a minimal dose of dobutamine was effective. Prehabilitation is important, and we are almost to the end. An entire workup that starts with preoperative, intraoperative, and postoperative, dedicated environment is effective. So again, we are almost to the point. Perioperative medicine is evolving. I would like to underline how research, clinical research, is an indicator of quality in care. And in conclusion, preoperative brain damage is an issue. There are different pathophysiological mechanisms, and some don't. No benefits in neuromonitoring, no evidence of anesthetic or steroid neuroprotection, avoids hydroxyethyl starch, and some do. Prevent hypoperfusion, optimize ventilation, prehabilitation, and dedicated preoperative workup, along with ERAS principles, are effective. Thank you for your attention.
Thank you, Federico. A very, very great talk, and I love Italian art, so it's very beautiful and fantastic.